Hi there, this is Professor Walton. I'm excited to have you with me today. We are going to be talking about the child with alterations in the musculoskeletal function. Some of those things that we're going to focus in on are fractures, scoliosis, DDH, DMD, and clubfoot. Keep in mind that musculoskeletal complaints are reported in 4 to 30% of young people. In most cases, the causes of pediatric musculoskeletal symptoms are benign and self-limiting. You have sports-related injuries, and they're found to be the highest causative factor of musculoskeletal complaints in 5 to 24-year-olds. Some common musculoskeletal disorders include athlete injuries, back pain, foot injuries, knee disorders, shin splints, and stress fractures. You also have some of those inborn problems that include spinal deformities, so like hip and foot anomalies, growth disorders, and developmental delays, as well as metabolic disorders and neuromuscular disorders ranging anywhere from cerebral palsy to muscular dystrophy. There's a wide variety of other conditions that can cause musculoskeletal findings, including things like child abuse, trauma, cancer, and juvenile idiopathic arthritis. You also have other deformities that can result from cultural practices. An example of that is using a cradle board. And then you have things like utero-packing problems that can cause deformities. So keep in mind that disorders of the musculoskeletal system present unique problems because of growth and development of this system and how this can contribute to the evolution of pathological conditions over time. So things like limited mobility, pain, and deformity can interfere with the lifestyle of a child, right? They're very, very active. Children with functional disabilities may not be able to fully participate in all activities with peers and family or have access to various occupations. They may also face challenges related to self-esteem. So let's get started. Muscles and bones can be affected by localized or systemic problems. The initial orthopedic problem can be symptomatic of a larger problem. So let's talk a little bit about systemic problems. They can include chronic conditions such as hemophilia, sickle cell disease, arthritic diseases, neurological problems like cerebral palsy, various cancers, including osteosarcomas and leukemias. Children with metabolic problems, such as vitamin D resistant rickets, have bony deformities. Acute systemic problems can also affect the musculoskeletal system. For example, viruses and bacteria can infect joints and bones. In developing countries, tubular infections of the bones are very common and devastating. So you have genetic problems as well, and many genetic problems have an orthopedic component. So things like osteogenesis imperfecta, or OI, that is a genetic disorder characterized by decreased levels of collagen, the major protein of the body's connective tissue. Children with osteogenesis imperfecta have bones that break very easily. So kind of brittle bone syndrome is something you may have heard it called before. And this can happen with minor trauma. Down syndrome is a consequence of a genetic anomaly of a chromosome 21. And the main orthopedic pathology is hypotonia and the possibility of loose capsule and ligaments. Children with Down syndrome have a higher incidence of scoliosis and dislocation of the hip, as well as leg calf paresis disease. They have inability of the patella and flat feet. Children with Marfan syndrome may have long spider-like fingers, low muscle tone, and a lax in the joints that are prone to dislocate. Severe scoliosis may develop in children with neurofibromatosis, Turner syndrome, and Noonan syndrome. Girls with Turner syndrome may present with a webbed neck, short stature, a deformity of the elbow, and a short fourth metacarpal deformity. Children with Noonan syndrome can present, like I said, with that web neck, clumsiness, poor coordination, and motor delay. Many orthopedic problems have a factorial inheritance pattern. So if one child in the family has a dislocated hip or scoliosis, the risks are going to be increased for other children. So the pediatric provider needs to understand that the genetic disorder and needs to be able to monitor any related orthopedic problems and consider the genetic implications, as well as providing families with appropriate genetic information or refer them for genetic counseling. You heard me talk about uterine packing deformities a little bit. So with this, the developing fetus moves its body parts frequently, and this movement influences that musculoskeletal development. So when the baby fills the uterine space, movements are restricted and body parts begin to assume a shape in which they are fixed. With in utero positioning, joints and muscle contractions can develop and are considered generally physiological in nature. So orthopedic deformities of the uterine compression include things like club foot, torticollis, hip and hip dislocation. There's some other things like metatarsus abductus and some other different things with the foot, tibia bowing, hyperflexed hips, hyperextended knees, contractures, and internal tibial torsion. So fetal movement is required for proper development of the musculoskeletal system, and anything that restricts that fetal movement can cause a deformation in the intrauterine molding. So you have two major causes for those deformities, and you've got things that affect the neuromuscular system. So you have those neuromuscular disorders. And then, like if there is not enough amniotic fluid in the uterus. So these intrinsic causes are related to like a fetal crowding that restricts that fetal movement. For a fetus in the breech position, the incidence of deformity is increased by 10. Occasionally, a foot may be turned awkwardly, and the legs might be fixed straight up, with the feet near the ears, or the neck might be tipped to one side. So these positioning issues are outside the range of normal, right? The outcomes of the deformities are going to vary in different degrees. The longer the position is maintained, of course, the more severe the problems are. So in general, there's a tendency for bowing and late deformities to straighten. However, the effects related to in utero positioning may not fully abate until the child is about 3 to 4 years old. So more serious deformities, so those are going to be that are way outside that range of normal, need to be referred to an orthopedic specialist for treatment as soon as they're found, because a softer skeleton is a lot easier to realign in a positive direction. Now let's talk a little bit about bones. I want you to review your textbook so you can get a more in-depth look about how bones form and grow. That way you can see how things will be affected if the child has an abnormality or an injury. So limb formation occurs very early in utero. So that happens about 4 to 8 weeks gestation. So you have that primary ossification centers that are present in all the long bones of the limbs by the 12th week of gestation. So do you remember what ossification means? That is the hardening of the soft tissue and laying down of new bone. So the ends of the long bones remain very cartilaginous, and that is where the growth occurs. So in that epithelial plate. So the way that those bones grow and mature down to a very cellular level is important, because if that gets damaged, ossification and hardening cannot occur as well as bone growth. So the skeleton is mature at about 20 years of age. You know, up until then, you're constantly having that bone growth and changes. So, but keep in mind, no matter what, bone growth can continue because, if you break a bone, then, the bone can repair itself. So a big component with bone health is calcium. So calcium is needed for new bone growth. And, it provides adequate bone density and it'll help prevent osteoporosis and fractures. So having a good intake of calcium is important. Bones of children are very, very porous and they're less dense than adults. So children's bones tend to bend, buckle, or break easier than adults because they are more porous, right? They're not done growing and maturing. So injury to that epithelial plate can impact any future growth. You have curvature of the spine, and that changes as the child holds the head up. So it starts out as kind of a C shape or a convex shape, and as the child learns to hold their head up and stand, the spine takes on a more S shape. So the development of bones and muscles is going to be influenced by use. So in infants and toddlers, the legs straighten and lengthen with the stimulus of that weight bearing and independent walking. The infant is born with a full, complete set of muscle fibers. So growth in the muscle length results from that lengthening of those fibers, and growth in bulk comes from hypertrophy. So the length of the muscles is related to growth in the length of the underlying bone. If a limb isn't used, it's going to grow very minimal. So keep in mind those disorders where patients cannot use those limbs, especially in childhood. If muscles and bones aren't used in their intended normal manner, the forces for development tend to stimulate growth in those abnormal patterns. So scoliosis can develop, or bowed legs may increase in severity. Muscle contractures occur if the muscles aren't used regularly and put through their full range of motion. The growth of fibrous tissues and tendons and ligaments also depend on those mechanical demands. So when we think about nutritional components, mechanical and hormonal factors also come into play during that growth process, and it influences the thickness of bones. So the health of the marrow is also taken into account with that nutritional, mechanical, and hormonal factors. So they're going to need adequate protein, calcium, and vitamin D in the diet. Those are key nutritional elements that affect growth and development of a child's musculoskeletal system. So the muscle structures originate from that embryonic mesoderm and include tendons, ligaments, cartilage, and joints. So muscle fibers are developed by the 4th and 5th month of gestation and grow in a tangent with their respective bones. So they grow right along with them. The rate of muscle growth, which is going to be, like muscle mass and cell sizes, speed up dramatically about 2 years old, and girls exhibit a higher rate of growth than boys until this gender trend is kind of reversed at puberty. Take a look at muscles. So the muscular system is almost completely formed at birth, and those muscles are completely formed at birth. So muscles increase in length and circumference, but not in number. Ligaments and tendons, however, have, those are stronger than bones until puberty occurs. When these structural differences aren't recognized, a childhood fracture is sometimes mistaken for a sprain. A sprain is a tearing of ligaments, the structural support connecting to those bones, and it's usually caused when a joint is twisted or traumatized. So when we look at tendons grow in length and fibrous tissue as a mechanical pressure is placed on them. So, this is where you have that contracture. Those can develop if those tendons aren't used. about metatarsus, adductus, and club foot. Okay, so what is metatarsus adductus? This is characterized by an inward turning of the forefoot. It affects males more than females, and the most common cause is that intrauterine molding that we talked about. The deformity is bilateral, so it's in both, in 50% of the cases, and there can be a family history as well. So we kind of call this like in-toeing, and so it's not really the legs, it's more just the foot. So it's a congenital foot deformity, and it is the most common. So they're going to do some diagnostic studies, and those will be done routinely. So how do we treat this? It's based on the rigidity and the deformity, but most children respond to a non-operative treatment. So for the flexible foot that can be brought past the midline, the soft tissues can be stretched by the parents with each diaper change. And stretching is done as described under the physical exam when the examiner determines whether the foot is flexible or not. So that they kind of learn, when the physician is doing the assessment. So you're going to want to instruct the parents to hold the hind foot with one hand and stretch the midfoot to overcorrect the deformity to the count of 5 and repeat that 5 times. The soft tissues should blanch with each movement. So serial casting is another treatment of choice for that curvature that's greater than 15 degrees or in cases that don't see improvement. So the infant's feet are placed in a position as close to neutral as possible and are held secure with casts. Casts are changed weekly until that desired correction is achieved. Braces and orthopedic shoes may also be used to maintain that correction after casting. So here you have a picture and you can kind of see what I'm talking about. So here you have where, that forefoot is turning inward and you have this convex or curvature of the lateral foot here. So on the left side of the foot is where you see that convex curvature, and then on the inner foot you see where that foot is turning inward. Now let's talk about club foot. This is a congenital anomaly. The foot is kind of twisted and it involves muscles, bones, and tendons. This is actually called, I may not pronounce it correctly, talipus equinovarus. So that is club foot. There are 3 elements. So the ankle is in that equinus state where the foot is in a pointed toe position. The sole of the foot is inverted as a result of this hind foot varius or inversion deformity of the heel. And the forefoot has that convex shape, so that forefoot adduction. The foot can't be manually corrected to a neutral position with the heel down. And 90% have that plantar fixed pointed outward. So the etiology of this may be idiopathic. So it could be hereditary, it could be neurogenic as well. You see this sometimes with a myomeningocele. It varies in severity with uterine positioning a factor in that mild clubfoot. The incidence is about 1 in every 1,000 live births, with approximately 50% of those causes being bilateral. The etiology is thought to be a multi-factor occurrence and likely involves the effects of environmental factors in genetically susceptible hosts. The problem is congenital and can be identified in neonates. And it's more common in boys. So when you see this, you're going to be looking at, the clubfoot is present at birth. You have the physical examination of the foot, and it's going to appear as described previously. You have a complete physical exam that should be performed to rule out any coexisting musculoskeletal and neuromuscular problems. So definitely going to be doing some of those diagnostic studies. So let's take a look at what that looks like. And pause this slide and just take a look, and you will see kind of exactly what we just talked about as far as the pathophysiology of the club foot and what it looks like. So be thinking about these questions. Parents are going to have lots of questions. Can it be treated? Will the child be able to walk normal after surgery? Will they need caring? Help to care for the infant, how much, is the surgery going to cost, how much is the care going to cost, will their other children have this? So be thinking about how you would answer those questions. Clubfoot treated. So they start with serial casting, and this is as soon as possible after birth. Those casts are changed every 1 to 2 weeks. So they're applied in increments, moving the foot into the proper alignment. Castings are going to be held into place until they have surgery. So surgery is done at about 3 to 12 months, and if it's also can if they have a mild case, casting may be the only thing needed, but surgery is done if that casting is unsuccessful based off of the degree of the deformity. So when we're looking at our nursing assessment, we want to look at motor development. We want to look at that at each cast visit. And also, thinking about family coping and economics. So you want to make sure you're informing the parents of the treatment and encouraging that bonding. You also want to educate on signs of neurovascular compromise and pain medications. So, anytime someone is in a cast, you're looking to check, you're always assessing that pain, their pulses, their pallor, their paresthesia, and paralysis. So, you want to keep in mind that timing is crucial because the short bones of the foot begin to start to form and ossify shortly after birth. So, we've got to get this started really early as far as the serial casting and then moving on to the surgery. Now let's talk about cast care. So you want to make sure that you are elevating the extremity to decrease that swelling. You want to circle any staining on the cast and note the date and the time, because that can indicate that something is getting worse. Maybe they have an open area and it is getting infected. Keep in mind this, cast is enclosed. A lot of times, there's a lot of heat in there and sweating, and what happens when that if that moisture gets bacteria in there, it can cause an infection, right? So you also want to assess the distal pulses. You want to be assessing for color, warmth, cap, refill, and edema. And then you want to assess sensation and movement of the area. So any deviation from normal can indicate nerve damage or a decrease in blood supply. So that's very, very important with cast care. You want to check the edges of the cast for any roughness. You don't want to cause them to get a sore or blister or cut or any type of injury because those casts are pretty rough when they get hard. So you want to pull that inner stocking over the edge of the cast, and you may even have to tape it into place. It's always good to tape it into place. And then keep the cast clean and dry. You can cover it with plastic wrap, and then there's also some other things that you can use for that. So, educate children not to place small objects between the cast and their extremity. Children tend to like to explore and put things where they shouldn't, whether it's up their nose or in their ear, or just think if they had a cast, what a cool place that would be to, put a car in there or Legos. There's lots and lots of different things thick and stick down in there. People get, they have an area and it might itch, and so they've, stuck fly swatter endings down in there. I think of all the germs on that. So anyway, we don't want to do this because that can cause irritation and that can cause neurovascular compromise. So don't, lots of education about not putting things inside the cast. So let's look at the 5 P's of a neurovascular assessment. So this is very, very important. So make sure that you remember this. So you've got pain, pulses, pallor, paresthesis. Can they feel it? Is it numb? And then paralysis. Are they able to move their foot? This is very, very important. This is how we identify if there is any neurovascular compromise or a decrease in blood supply. So this is always done after surgery during the first 24 hours every 15 to 30 minutes. We usually do that every 2 hours and then every 1 to 3 hours thereafter. And then for the next 2 days, we want to be checking the 5Ps for about every 4 hours because, if they have surgery or the affected limb is not responding well, it can cause edema. And what happens then? It cuts off their circulation. What happens if there's no circulation? Hey guys, thanks for sticking with me. I know some of the slides have been pretty lengthy, but this is a big thing pertaining to children. So now we're going to move on and talk about disorders of the hip. We're going to talk about developmental dysplasia of the hip, or DDH, and then we're also going to talk about slip capital femoral epiphyseal. Developmental dysplasia of the hip. So this is where the femoral head and the antebellum is the socket of the hip bone, and so that femoral head is not properly lined up with that socket. This is the socket of the hip bone where the femoral head fits, and it doesn't line up. So with developmental dysplasia of the hip, this represents a spectrum of anatomic abnormalities in which that femoral head and the antebellum are not properly lined up. It can also grow abnormally. So this occurs congenitally, or it develops in infancy or childhood. Dysplasia may be diagnosed many years after that newborn period. So you have hip instability, you have a dislocation. These are different types. Dislocation of the hip from the normal position in which it sits in the joint, and then you have subluxation. That's where the hip is unstable and the head of the femur can slide in and out of the antebellum. And then you have dysplasia. That's where it's more shallow, more vertical in that socket, in that antebellular socket, and then you have an immature hip. Girls are affected 4 more times than boys. 80% are unilateral, so on both sides. The left hip is affected about 3 more times than the right. With developmental dysplasia of the hip, the etiology is sometimes thought to be unknown. It appears that genetics can play a role. A fetal insult at about 12 to 18 weeks when the lower limbs are developing, and as well as those surrounding muscles develop. You've got mechanical forces that can cause this, so like a constant pressure in utero with a restriction of those movements late in gestation. If the fetal pelvic gets locked in that maternal pelvis, this can occur as well. And then maternal estrogen levels. So hormonal effects have, issues and can cause issues with like temporary laxity of that hip joint. So when we look at clinical manifestations with this, you will see a limited abduction of the affected hip. So you have that reduced movement on the side of the body where it's dislocated. And then you have the asymmetric visual appearance of the gluteal and those thigh fat folds. So, you can kind of tell maybe that you have a shorter leg on one side than the other, so that leg that's dislocated is going to, be evident related to that. So, you've got those uneven folds of the thigh of, where the fat is in the thigh. And then with the older child, you might see where they limp. So after 3 months of age, the affected leg may turn outward or be shorter than the other if it is not caught. So, keep in mind the hip is a ball and socket joint. The ball, called the femoral head, forms at the top part of the thigh bone, which is the femur, and the socket, the antebellum, forms in the pelvis. So the hip may be all the way out of the joint, or the socket may be a little shallow. You can have one or both hips involved, and the cause is unknown, but genetic factors may play a role. As well as like things like that lower level of amniotic fluid in the womb, and that can increase that baby's risk of developmental dysplasia of the hip. And other risk factors are some things kind of like the first child being female, breech delivery, a family history of the disorder, and this occurs in about 1 out of 1,000 births. And in the labor and delivery room, you notice that after the baby is born, the physician will always be moving their little legs around and assessing for this. They also assess at pediatric appointments. So some things that you will notice are these uneven fat folds here of the thigh in the middle picture. And then, the baby, you've got the little baby in the left upper corner. This baby is in a spica cast, and this is to help immobilize the hip thigh so that the bones or tendons can heal properly. So you don't want to forget cast care and checking those neurovascular checks with that one. You can also see down here you have a Pavlik harness. So this is a splint and it doesn't allow any hip extension or adduction. And then over on the right hand side of the screen, you see where this baby has the hip location and the physician is forcing it back in place. This can be done with an ortolani or a Barlow dislocation. Here in the center of the slide, you see a picture of what developmental dysplasia of the hip looks like. So you can kind of tell that this kiddo's leg's a little short, and you see that uneven folds in the thigh, right? So when this happens, they can be put in a spica cast, which is here on the left-hand side of the screen at the top. That will immobilize the hip and the thigh so that the bones or tendons can heal properly. Then you have a child down here in a Pavlik harness. This is more of a splint and it doesn't allow any hip extension or adduction. Now over here on the right hand side, you see where this child has a positive or Lottie and or Barlow reflex or sign, sorry. So that indicates the dislocation. So that doctor is moving the hip around and if they have that, sometimes they can force the hip back into place. So let's move on and talk a little bit more. To diagnose developmental dysplasia of the hip, we're looking for that positive Ortolani and Barlow maneuver. So they routinely screen all newborns and infants for the hip dysplasia. There are several methods to detect this dislocated hip or a hip that's able to be dislocated. The most common method of identifying this condition is a physical exam of the hips, which involve applying pressure while moving the hips. The healthcare provider listens for any clicks, clunks, or pops. They can also do an ultrasound of the hip, and that can be used to confirm the problem. An x-ray of the hip joint may help to diagnose the condition in older infants and children. A hip that is truly dislocated in an infant should not be detected at birth, but some cases are mild symptoms and may not develop until after birth, which is why multiple exams are recommended. So some mild cases are silent and can't be found during that physical exam. So, with that positive Ortolani and Barlow maneuver, you will see that one knee will be lower than the other one when it's flexed. So treatment for this is going to consist of, in early infancy, they usually have a non-surgical positioning device that keeps the legs apart and outward. They kind of have like a frog leg position, and that's where we've seen that Pavlov harness. That's the most commonly used for that hip reduction. And that device will usually hold the hip joint in place while the child grows. If there's a problem in maintaining that proper position, that's where you see that cast on the child's leg, and it's changed as the child grows. So for infants over 6 months, surgery with a closed reduction is generally performed, and getting that position of the femur into the antebellum without an incision of the skin, and then they kind of can follow it by the application of that spica cast, just depending. So sometimes they need surgery with a closed reduction, and then sometimes, they move on and they have that spica cast. So in older children, 18 months, an open or closed reduction of surgery and casting are usually necessary, and bracing may also be required. So, what's the prognosis? So some expectations. If the hip dysplasia is identified in the first few months of life, it can almost always be treated successfully with that positioning device using the braces. In a few cases, surgery is needed, and that's to put the hip back into the joint. And then with hip dysplasia identified after early infancy, it might be associated with a worse outcome and might require more complex surgeries to repair that problem. So some complications with this are bracing devices can cause skin irritation. There's going to be differences in the lengths of the legs, and they might persist despite appropriate treatment. And then untreated hip dysplasia will also lead to arthritis and a deterioration of that hip, which can be very, very severely debilitating. So call the health provider if you suspect that, a child's hip is not properly positioned. Nursing management for developmental dysplasia of the hip is going to include that assessment. So, first of all, you want to make sure that you are properly identifying that developmental dysplasia of the hip. And then once it's identified, you have to make your assessments based on the risks involved in the treatment. So you're assessing the skin of the child, especially if they're in traction or in a cast, and that should be done every few minutes in the immediate post-op period, progressing to, once or twice daily at home. So just think about casting and bracing devices and those assessments that you will be responsible for. So you're looking at respiratory and circulatory assessments, continuous assessment of those growth and developments, obtaining a cast weight for baseline after the cast is dry is appropriate. And then, a lot of that Management can include like maintaining the traction, providing cast care, applying and keeping the cast clean and dry, using plastic covers to protect the cast during elimination. With the Plavix harness, you'll have the harness applied in the healthcare facility, and then the parents will be instructed on maintaining it at all times. So, you want to focus on preventing complications resulting in immobility, assessing those breathing patterns and lung sounds, performing skin assessments, neurovascular checks every 2 hours, and changing positions every 2 hours. Like prone or supine with pillows to support and protect the skin and the irritation from the cast, when they're in the hospital after they've had a procedure or these things applied to them. So you want to increase fiber and fluids to help with those bowel and bladder problems, and just, focus on promoting normal growth and development. So you want to engage those children in activities that stimulate the upper extremities and all 5 senses. So interact with the child as much as possible and teach the parents about the condition and the cast care. So neurovascular checks, right? That's a big, big thing with casts. So don't forget that in the 5 P's. Thanks for hanging in there with me, guys. In this section, we're going to talk mostly about scoliosis, but another disorder of the spine is also called torticollis. So this is where you have a tilt of the head, and it's caused by a rotation of the cervical spine. The cause of that can be birth injury or cervical spine abnormality, and we treat that with stretching exercises, and then sometimes they have to go in and lengthen the sternocleidomastoid muscle. So that's pretty much, that covers that torticollis. So we're going to focus on scoliosis now. What is scoliosis? This is a lateral S or C-shaped curvature of the spine associated with a rotational deformity of the spine and ribs. So curvatures of more than 10 degrees is considered abnormal. The curves can be either idiopathic or compensatory. So this is where the body is compensating for structural deformities. So maybe leg length and a discrepancy in that. Most often, idiopathic is seen in girls during growth spurts when they're about 10 to 13 years of age. So what are some clinical manifestations? So you're going to see that trunk is asymmetrical. Maybe uneven shoulder and hip height is a big one. And then one-sided rib hump. So they have a hump on one side of where their ribs are. And then a prominent scapula. That look like? So when the child is standing in front of you, you may notice some of these things. So with the first one, you've got that S shape. The second one, when you have them bend over and hang their arms loosely, you can see here that they have a rib hump, and you can also see where the hips are uneven, right? So with this, you see where there is a deviation in their right thoracic area on the last picture. So what are we going to do about this? The goal is to stop or limit that progression of the curvature. So early detection is very, very critical. So treatment of mild sclerosis is when you have that 10 to 20 degree deficit. That's going to consist of exercises to improve posture and muscle tone and maintain or possibly increase flexibility of the spine. So there's an emphasis placed on building strength toward the outside of the curve while stretching the inside of the curve. So they usually have follow-ups every 3 months and x-rays every 6 months. So with moderate scoliosis, you've got that 20 to 40 degree discrepancy, and that's going to include bracing with a Boston brace. The goal of wearing that brace is to maintain the existing spinal curvature with no increase, and the brace begins immediately after diagnosis. The brace should be worn 23 hours a day, so basically off for showers. Um, Keep in mind this, you've got girls that are wearing this and they're all about body image, right? So how's that going to affect them? So with severe scoliosis, you've got a 40 to 50 degree deformity, and it generally is going to require surgery, which is going to involve a spinal fusion. So school nurses, sometimes screen between 5th and 7th grade. Some states mandate that. I've noticed since COVID, that's kind of fallen away. So I don't know if we'll get back to that or not. What does scoliosis screening look like? You can find it in your book, but first and foremost, you have the person stand with weight equally on both feet with the legs straight, and you have the arms hanging loosely at both sides. So you do that when they are standing in front of you, and then you can also have them bend over and have the arms hang loosely at both sides. So kind of look back at those pictures and you see in one, the girl is standing straight and then the girl is standing bent over, and that's how you kind of assess that. So their legs are equal and straight on the ground, and the arms are hanging loosely at both sides in both of those positions. How do we screen for scoliosis? What does that look like? If you go back to the slides and you see the girl that was standing straight and then she was bent over. So you kind of picture that. So they're going to stand straight with weight equally on both feet with the legs straight. The arms are going to hang loosely at both sides. So you're going to be looking at their spine, looking at their back, their hips, their shoulder, and then you have them bend over, and again, the arms will hang loosely, the legs will be straight, and you also look at the hips, the spine, the back, and you're looking at their shoulders. Nursing care for scoliosis is going to center around some things. So education is one. So adhering to the prescribed measures is very critical for that treatment. So we talked about surgery, we talked about braces, we talked about exercises. So keep that in mind and know that you're going to have to provide lots of education. Kids think that they're invincible and nothing can happen to them. And oftentimes they don't understand that if they don't apply the braces or do the exercises, that it's going to get worse and it's going to affect them for the rest of their life. So if they do have to have surgery, you want to focus on that deep breathing, positioning, and the surgical incision, as well as that pain management. So you're going to have lots of emotional support with these kiddos. So keep in mind there's going to be limited activity for 6 to 8 months. So the child can usually walk and perform gentle physical activity like swimming, but things like lifting heavy loads, bending, twisting at the waist, or engaging in activities like roller skating, rollerblading, bicycling, they're going to have some restrictions with those for about 6 to 8 months while that heals. Other disorders of the bones and joints. Some of those things are osteoporosis, osteopenia, and osteogenesis imperfecta. So let's dig into those a little more. With osteoporosis, you see a decrease in the density and mass of the bones. So there is greater than a 2.5 standard deviation below norm with that. So a lot of times it's related to an imbalanced nutrition, and osteoporosis is preceded by osteopenia, which is a low bone mass. So osteopenia, like I said, is that low bone mass. And there's a 1 to 2.5 standard deviation below the normal with that in that bone mass. So those at risk are very low birth rate infants who are premature because much of the bone mass is usually acquired in the later weeks of pregnancy, and it's related to an inability to ingest enough nutrients. Also, preemie infants are less active, which decrease the amount of the mechanical loading on our bones. So that's also known to increase bone reabsorption and decrease that bone mass. So, Other groups of children at risk for osteoporosis that have decreased are those that have decreased mechanical function. So children like spinal bifida and cerebral palsy or lack of ambulation, you know, are seen. So, activity builds that bone mass and increased activity of the cells that break down the bones. So you have that increased loss of calcium. So some diseases are associated with lower bone mass, like Turner syndrome, growth hormone deficits, and diabetes mellitus. So also, children treated for disorders or injuries with casting and bracing are at a higher risk of osteoporosis due to that immobilization. So with adolescents, you see a decrease in intake of calcium and vitamin D that's actually needed for bone formation. So you want to, encourage them to have better nutrition because those adolescents do choose, a lot of times, they just have poor nutrition. What are some signs and symptoms of osteoporosis and osteopenia? So signs and symptoms, usually there's not any for years, not until a baby or child has a fracture or an x-ray showing the problem. As far as medical management, you want to enhance nutrition of formula and special fortifiers. They may need internal or parental nutrition. Range of motion and exercises is used to decrease that bone loss after birth, and exercises decrease the loss of bone strength and enhances the bone health, right? So you also want to encourage supplemental vitamins such as calcium and vitamin D. Standard therapy for children that are non-ambulatory is also needed. So when we look at our nursing care, as far as our assessment, we're looking at identifying those at risk. So like premature, adolescents, diseases that put the child at risk, especially those malabsorption diseases. We want to ask them about exercises and what they do, and ask about dietary intake. Do that dietary analysis. We're also going to be administering medications as prescribed. And then, looking at signs and symptoms of fractures and teaching that. So you have some signs and symptoms of fractures are things like edema and unusual shape, fussiness, and falls should be reported. Genus imperfecta. This is more commonly known as brittle bone disease. So their bones are very brittle, and they also have a connective tissue disorder. So children with this disorder have those fragile bones that are more likely to fracture. The underlying disorder is a biochemical deficit in the production of collagen, and the disease is genetically transmitted. So some signs and symptoms that you are going to see are things like multiple and frequent fractures, a blue sclera. So the sclera is thinner due to the decreased collagen formation in the veins end up showing through. Thin, soft skin, short stature, enlarged anterior fontanelle, weak muscles, soft palpable brittle bones, and possible hearing loss. So this diagnosis is normally made when the child obtains a fracture. There's genetic testing that is available, and there is no cure for this. What does medical management look like with osteogenesis imperfection? So it consists primarily of, fracture care and prevention of deformity. So the goal is to maximize the child's independence and mobility while minimizing that risk of fractures. So treatment can include physical therapy, casting, bracing, splinting, and surgical stabilization. You also have nutritional management with high vitamin D and calcium, and a biophosphate medication. So this is going to help prevent loss of bone mass. Dental and hearing exams are also very, very important. Nursing care for osteogenesis imperfection is going to include education, right? Prevention of those complications and nutrition, growth and development. It's basically supportive, and it's going to focus on educating the parents and the child about the disease. Child abuse may have been suspected. Recently, you may have seen some cases where children were taken away from their parents because they thought that the child was being abused when actually they had osteogenesis imperfecta. We want to focus on preventing those fractures, handle carefully and gently. Things like diaper changes and bathing could cause fractures. Diaper changes, maybe just slip a gentle hand under the hips, don't lift their legs, encourage a well-balanced diet with that vitamin C, D, and calcium to promote healing and bone growth. And, if those children are overweight, we would want to limit calories because that can cause stress on bones. Our big focus is on growth and development and allowing toddlers to explore. But remember, toddlers don't have that factor of how to stay safe, right? So you want to make sure that they explore in a safe environment. We also want to encourage socialization and exercises. So a lot of times they don't need to do any sports. However, swimming is a great exercise for these patients. We're going to talk about muscular dystrophies. So Duchenne muscular dystrophy is going to be our focus next. Muscular dystrophies are a group of inherited disease characterized by muscle fiber degeneration and muscle wasting. The disease can begin early or late in life, and the onset can be at birth or gradual. They are a terminal disorder, and the progression can vary. So we are going to talk about Duchenne muscle dystrophy, and it is the most common. There's one for every 3,500 male births. It causes an enlargement of the muscles, and it's a result of their infiltration with fatty tissues. So some signs and symptoms are going to be Gower's maneuver. So children will compensate for lower extremities by using their upper extremity muscles to raise themselves to a standing position. You also see delayed walking, frequent falls, tires easily with activity. So with this, the onset is generally within the first 3 to 4 years of life. So you have a normal baby, and as they get older, you notice some changes. So, how do we manage muscular dystrophies? We're looking at steroids, physical therapy, and rapid treatment of any respiratory infections. So the diagnosis is based off of clinical signs. Testing such as muscle biopsies could be used to confirm that diagnosis, and this measures dystrophin, the muscle protein that is deficient in muscular dystrophy. CK is elevated early in the disease, and genetic testing can specify the type of disease. There's not a lot of effective treatment, so we're just looking at managing it. So steroids can be given to preserve the muscle function, and PT is needed to minimize that independence and decrease effects of that immobility. With muscular dystrophies, we want to make sure that, we're providing lots of emotional support. So normally all body systems become involved and emotional care is needed, and it's very important. So, we want to promote independence and mobility with these clients. And, monitor their cardiac and respiratory function, their urine and bowel function, because like I said, all of the body systems end up becoming involved. So, looking at development, early intervention programs, measuring growth, monitoring overweight children, and nutrition. So, we're going to look at, a 24-hour analysis and a high calorie formula that may be needed. So with physical activity, we want to monitor their physical ability at each appointment. They're probably going to have some PT for range of motion and positioning of those extremities. With ADLs, we'll get OT in there, and they'll help with the abilities of performing those ADLs. So as far as disease prevention, we want to look at, these kids are very compromised as it is. So, making sure they're getting their vaccines, avoiding crowds, noticing any signs and symptoms of infection and treating that very rapidly. Encourage that deep breathing and use of that incentive spirometer, because like I said, this is a muscle wasting disease. So, we use a lot of our muscles to breathe. A lot of these muscle dystrophy patients end up, on a vent and things like that pretty quickly. Now let's move on to injuries to the skeletal system. This can include things like fractures and sports injuries. With fractures, that is where there's a break in the bone that occurs when more stress is placed on the bone than the bone can withstand. Fractures are more common and frequent in children because their bones are less dense and more porous than those of an adult, right? That's important for you to know. Fractures occur most often in the clavicle, tibia, ulna, femur, and distal forearm. So you see this sometimes, hopefully you never see it, but it is seen in child abuse. So what type of fracture is it? And is it common for that age group? So, oftentimes a femur fracture in an infant or a rib fracture is seen with child abuse. Um, you know, um, but, keep in mind, if these guys have a spiral fracture, that could be an issue as well. Pertaining to child abuse and can indicate that. So, what you look at that child age group and you look at what they're doing, and is that fracture possible to determine if the fracture is due to child abuse. So these fractures can also be caused from just injuries. Injury to the epithelius can interfere with that bone growth at that site. So we're always looking at that. We're looking at that growth plate, making sure that it isn't injured. And if it is, there's a lot more monitoring that's done with those injuries where the fracture is at the growth plate. So some clinical manifestations that you see with this is going to be like pain, abnormal positioning, edema, immobility, and that decreased range of motion. So here we just have a kind of refresher for you about different types of fractures. So the first one is oblique. The next one is a commuted. Next you see a spiral. Would you say that spiral is caused by a twisting of the arm, right? Which could be seen with child abuse. You've got that compound fracture, a green stick, a segmental, and a transverse. What do we do medically for fracture? So what's the medical management? First and foremost, we need an accurate diagnosis. And so we're going to get x-rays to determine the exact location and the type of fracture. And we also want to focus on pain management. And they are going to be in pain. Do you remember those pain scales and what to use? Sometimes kids don't tell you that they're in pain. So, keep all of that in mind. And then, we also look at reduction to align that displaced or fragmented bones. And that's performed and then the immobilization is going to happen so that healing can take place. So you have closed reduction. That's going to align the bone by manipulating it manually or by traction. And then you also have an open reduction. That's going to where it's that's going to be where it requires surgical alignment of the bones, which is going to be using like pins and plates and wires and screws. So again, we've got that reduction of the fracture, whether it's closed or open method, then that immobilization. And the immobilization can be used, by doing casting or the traction. So when we talk about nursing care, we talk about mobilization of the joints. Generally, that is going to be above and below the injury by using splints. Casts and tractions can also be used to immobilize that injury. So we want to make sure that we're assessing and evaluating the pain, edema, and abnormal position. So when we focus more on our nursing assessment, we're going to be looking at pain, vital signs, and monitoring for complications such as a fat emboli. And infection. So we want to focus as well on compartment syndrome. Do you know what that is? That can happen following a reduction. So this is a condition of increased pressure in a limited space, such as the soft tissue of an extremity that's compromised. And so that compromises the circulation and the nerves in that area. So you want to be on the lookout for that. And then, you're also going to be looking at your neuro assessment, right? So monitoring that sensation to touch, temperature, movement, and strength of the pulse and the cap refill. And you want to look at that in the extremity distal to the injury. So you're going to be monitoring every 15 minutes after the cast is applied for about 2 hours, and then every 1 to 2 hours. So those neurovascular assessments are extremely important. So here you see something that's very useful, and this is a water guard for casts. This can be used over and over, but it will keep the cast dry. So you may want to talk to the patient about this. They can find this on Amazon or online somewhere, unless you are at an orthopedic place that actually gives them out. But this is great because this is always a big concern. Kids break a lot of bones in their arms, and so you oftentimes see kids with casts on. So this is a great tool. Just a little bit about care of a client and traction. So we've talked quite a bit about casts. So when a child is in traction, you've got a mnemonic here in front of you. So you want to, keep that in mind. You're looking at the temperature. So, in that extremity, you're looking for infection, right? The ropes are going to hang freely. You want to look for alignment. You want to check for circulation, those 5 P's. You're looking at the type and the location of the fracture. You want to increase fluid intake. These kids usually have an overhead trapeze, and there's going to be no weights on the bed or floor. This is all freely flowing things. So, with the skin, you want to make sure that you're looking at assessing their pain, their bowel sounds, their cap refill, and that skin integrity. So you want to be definitely doing a lot of inspecting on these clients. So let's briefly talk about sports injuries. Kids play a lot of sports, right? That's where they're the most sportsy in their lifetime. So the most common injury in youths from the ages of 13 to 19 occur related to sports. So things like football. Football is a big one, right? Cycling and basketball are most associated with injury. So those are, the common sports. You've got a table in your book that talks a little bit more about sports injuries. So some characteristics that are going to put these kids at risk. So, kids versus adults. So this is why they get hurt more with sports than adult athletes that you see. So, they have that vulnerability in those growth plates. So, those weaker areas are more prone to injury. They have an increased joint mobility, because those tendons and ligaments are more lax. And then they have more porous bones. So, that makes them prone to more fractures. You have more pores in something versus something that is solid. So if you think of a sponge, and the harder sponges that have less pores in them don't move as well as a sponge that is softer, right? So then you have lack of experience or training in the sport. This is where they're learning, right? And then protective gear. Do kids always use protective gear? No, they don't. So, you want to make sure that you're encouraging and educating on protective gear. And then, a lot of times, they don't want to give the injury time to heal. They overuse it. They need to be resting and healing. So, kids get all of these injuries from sports, whether it be basketball or volleyball, and they want to, they're so competitive. They want to get back out there, and they don't give themselves time to heal. So healing time is extremely important. When a child becomes injured in a sport, you want to make sure that you are doing a thorough assessment and providing education based off of what's going on. A lot of these kids experience sprains. So use the RICE acronym for about 24 to 36 hours with that sprain. If you don't remember what a sprain is, we kind of talked about that, where you've got that stretching and that inflammation of the tendons. So go back and look at that if you don't remember exactly what a sprain is. So we want to focus for sprains on rest, ice, compression, and elevation, right? That's what's going to help the most with those things. But often those are mistaken for an actual fracture. So just keep those things in mind. This concludes our presentation about pediatric patients. If you're in my online course, this also, concludes our course on pediatric patients. So I just want to thank you, and thank you for choosing to be a nurse, and thank you for investing your time and money and energy into providing care to patients, across the spectrum, not only these pediatric patients. So I hope that you have a great rest of your day. Let me know if you have any questions.